in this session about difficult situation in heart failure. I have to speak about the patient with hyperkaliemia. For this situation, hypertension, I don't have any conflict of interest. I present me for whom don't know me. I'm Dr. BEN SLIMA, head of the department of cardiology department in Masbourguiba Hospital. So, hyperkalemia is an important item that we often see in heart failure. As you know, heart failure is a global health challenge. Today, medical landscape boasts a multitude of treatments that have substantially enhanced patient diagnostics. But, however, full implantation often faces barriers, and one of the most barriers is notably hyperkalemia. Why hyperkalemia is a problem, a huge problem in heart failure? Because the levels of problems, that's if the ideal average of kalemia is potassium rate is from 4 to 5 millimole per liter. Even hypo and hyperkalemia are related, associated with an increased risk of death. And hyperkalemia is one thing that we see every day in our daily practice. 5% of potassium rate are more than 5 millimole per liter. And in one year follow-up, you can hyperkalemia occurs in 40% of chronic heart failure and more than 70% of chronic kidney disease. So it's really a problem in our daily practice. The problem and that hyperkalemia, along with renal dysfunction, are the major cause of underuse of renin, angiotensin, aldosterone system inhibitors, and mineralocorticoid receptor antagonists in our clinical practice. So, hyperkalemia is defined as a serum potassium more than 5 millimole per liter. It can be classified as mild for 5.0 to 5.5 millimole per liter, moderate from 5.5 to 6, and severe for more than 6 millimole per liter. Hyperkalemia can be associated with administration of renin, angiotensin, aldosterone system inhibitors, chronic kidney diseases, and increased absorption. We will not speak about emergency situation with acute heart failure with main critical symptoms requiring urgent hospitalization. We'll speak about a situation in daily practice for this presentation. So we have a case report of a 68-year-old male with a history of heart failure and chronic kidney disease stage 3. This patient took many treatments, enalapril, carvedilol, furosemide, spironolactone, dapagliflozin, and latest lab result showed a serum potassium of 5.8 millimole per liter. So our patient is taken enalapril and spironolactone, which are what we will do with this treatment. Should we stop? Should we control? That are the question. So to respond to this problem, to the question, we have this expert consensus which has published 2 years ago. And this expert consensus recognizes a stepwise approach. We begin by assess, then by adapting treatment, then by monitoring kalemia. How can we assess? How is this three steps approach? First, we should assess. The assessment is important. Always confirm with always confirm kalemia with another test or measurement as you say, there is much of hemolysis that can be others in kaliemia, then we should evaluate the day intake of potassium. As you say, we know there is more of a salt dietary. There is many foods that increase potassium rates. Third, we should evaluate hydration, congestion, blood pressure, and kidney function. Then we should check if there is a recent treatment changes, as for example, recent administration of immunocorticoid antagonists. And after the first step of assessment, the second step is to adapt, then to treat. How to adapt? First, we should adjust potassium intake and optimize blood pressure and hydration. We should consider, it's not very often used, cation exchange reason. There are many new molecules that are now in the market, and there is many studies that have been recently published, and that showed that prescribing these treatments permit to have lowering of kaliemia rates, and permits to maintain the drugs doses. And what says the guidelines? The last guidelines published 2 years ago. There is no change this year for this item. There is what say the guidelines. So the guidelines in all the situations preconize to close monitoring of potassium levels. However, whatever is the potassium level, lowering agent potassium are indicated for potassium level more than 5 millimole per liter. For uptitration of renin-angiotensin-aldosterone system inhibitors are permitted only if potassium rate is inferior to 5 millimeter per liter. And guidelines, latest guidelines, preconize to continue the treatment of renin-angiotensin-aldosterone system inhibitors until 6.5 millimole per liter. There is much of controversies, I know, but they prefer to continue because of their benefits, and to check the rest of the item, then to stop the treatment. And the latest guidelines. After the treatment and adjustment to treatment, there is the third step is the step of follow-up with biological control of potassium, urea, creatinine in the next 7 days after seeing the patient. Control vital signs, monitoring of weight and blood pressure, and the clinical follow-up should be done by a nurse, by a general practitioner, by cardiologists, and by nephrologists. So, for our case report, case presentation, what should we do? We should recheck serum potassium and evaluate current renal function, order an EKG to check hyperkaliemia, induce change, and treat if necessary. Then prescribe potassium binders, and also continue renin-angiotensin-aldosterone system inhibitors and uptitrate as soon as potassium levels are dropped underneath 5 millimole per liter. To conclude, it's blocked. Three take-home messages. The first take-home message is to prevent the risk of hyperkalemia, because hyperkalemia is both common and perilous in heart failure patients. The second message is to, in mild and moderate hyperkalemia, we should not immediately precipitate the cessation of renin-angiotensin-aldosterone system inhibitors because of the proven benefits. we should close monitoring and judicious adjustment of hyperfed. And while medication play a role in hyperkalemia, it's essential to consider other contributing factors such as diet, such as kidney function, and its management. So, Mrs. Thank you.